Hey, welcome back, everybody. Looks like most of the crowd is back with us. A couple of people had to go all the way to Brooklyn to get their bagels, but I'm sure they'll be back in a minute. Thank you for joining us for the last part of this session. We're going to have a great afternoon, and we're going to kick it off with Dr. Connie L. She is an infectious diseases physician, an epidemiologist, and one of the world's foremost clinical researchers in the area of prevention of HIV and other sexually transmitted infections. She's a professor of global health, medicine, and epidemiology, and director of the International Clinical Research Center at the University of Washington. Connie was co-chair of the Partners PrEP study, which you may remember that contributed to the FDA approval of TDF-FTC for PrEP in 2012. And she is now focusing on implementation science research about PrEP and STI interventions for young African women and gay and bisexual men in the U.S. And so today she is going to talk with us about the challenges and the successes of PrEP implementation. Dr. Celum.
Thank you so much, Melanie. That was a really nice introduction. And it's really a pleasure to speak to this group about now it's almost, approaching a decade of experience in taking our first generation oral PrEP and learning from trying to deliver it. And just as a quick intro, I felt like I kind of had the impression that your job is done when you do the clinical trial and you demonstrate efficacy. And I realized it's actually much harder than I ever would have imagined to know how to deliver new interventions. And so I've really learned a lot in the past 8-9 years since we had those, since Partners PrEP and other trials showed effectiveness of TDF-FTC. So just to jump into it, I think that I like to show this slide because it reminds me that, yes, we do have many, many countries that are implementing PrEP, but we're far from the UNAIDS target of 3 million people on PrEP. And you can see, if you can read the graph, that there's pretty small numbers in many parts of the world. So we should celebrate that we've come a long way, but we also need to be motivated to try to learn from the lessons and address the challenges. So in terms of my disclosure, I did receive support in terms of provision of medications from Gilead Sciences for Partners PrEP, and I've been a scientific advisor to Gilead and Merck. So I'm hoping that through this talk, that you'll be able to identify examples of successes and be familiar with challenges with PrEP delivery, and both in the U.S. and globally, that you'll be able to understand the great potential for population-level impact of PrEP and where it has been demonstrated to have a population-level impact, and then be better prepared to implement choice of PrEP formulations in the future, again, utilizing lessons learned from delivery of oral PrEP. So I appreciate Dr. Nitya Panapak, who gave a great talk at AIDS 2020. If you didn't hear it, I recommend it, where she really brought this notion of a cascade, which has helped us so much in terms of our thinking about how to deliver ART to PrEP. And I want to say really clearly, and I'll come back to this at the end, that the cascade looks different and always will look different for prevention and treatment. That whereas we're aiming for 95, 95, 95, if we can get there, and I hope we can, for treatment, we're going to see fall off for different reasons for prevention. It is not a lifelong intervention for the vast majority of people. So let's just briefly go through an overview of the prevention cascade lens. First, the denominator is the people who need it, and that changes during people's sort of sexual lifetime, if you will. Then there's motivation, and ideally we want to get both people who need it and are motivated to use it, and we need to identify interventions to help people who need it but aren't motivated. Then there's access, and how do we get those who need it, are motivated to be able to access it. And then there will also be some drop-off for people who meet all those criteria but then are not able to use it. So let's use this framework to think about what we've learned with oral PrEP. And I need to remind people the reason why we're even having this conversation is that we've really sort of stalled out in terms of progress in HIV prevention in the U.S. And just as you can see that in terms of number of new infections. You can see it in the majority of transmission categories based on race, ethnicity, and behavior. And where you can see in 2018, the red bars in some cases are going in the wrong direction in terms of like Latino, gay and bisexual men. Really the only group where we've had a substantial drop between 24 and 2018 in number of new infections is in white, gay, and bisexual men. And this is shown in a different way in this slide that just shows over those same years the trend where we're seeing an increase in new infections in the last in the 2014 to 2018 timeframe between for African and American and Latino MSM, whereas we're seeing a little downward trend for whites. So that's why we're talking about this. And finally, in the U.S., we have a strategic plan, and it's kind of always a little disturbing to realize how long it took us to get here. But that there are 4 pillars to ending the HIV epidemic in the U.S., and this is true globally. We have to do a better job at diagnosing HIV infection by increasing HIV testing, particularly in populations that are not that have a higher proportion of persons not knowing their status. We have to do better at treatment and retaining people in care and achieving and sustaining viral suppression. We have to do as a much better job in prevention. That's where our biggest gap has been, I think, in terms of increasing both primary and secondary prevention, because treatment is also prevention. And then lastly, use increasing number of kinds of tools, including molecular surveillance and outbreak investigations to respond to new settings where we're seeing new infections. And if we could do this well, and we should be able to do this well, we have the tools, we should be able to reduce HIV transmissions by 75% by 2025, which is feeling like it's around the corner. So the plan really focuses on the jurisdictions that have accounted for 50% of new HIV infections in the recent past. I want to highlight one thing that is an underpinning when we think about HIV prevention in the U.S., and this was a paper I refer you to by Aaron Siegler in Annals of Epidemiology, how important it is that we not just silo HIV as a separate health issue, that having policies in place that support treatment and prevention are essential. And the single biggest factors that accounted for PrEP use in the U.S. in 2018 were whether or not they had a state drug assistance program for PrEP and Medicaid expansion. So keep that in mind, because while we may be passionate about doing something about HIV, we can't have such a narrow lens that we forget that we have to improve healthcare access generally to achieve our goals. So I'm going to now shift to kind of a different part of the talk and talk about some of the successes and challenges. And I thought it was useful first to talk about tale of cities, and in this case, the tale of PrEP in U.S. cities, starting with San Francisco, which has really put a lot of effort into improving both ART treatment and PrEP as being one of the fast-track cities. And, they have about 78%, if you remember that cascade of starting with people who are evaluated for PrEP and therefore at need. 78% initiated PrEP. And if you can read the small print below, the single biggest issue why people didn't make it from evaluation to initiation of PrEP is cost or insurance issues. And and then there were about 47% were retained in PrEP. And these numbers vary by city, but in general, we're in cities that have really dealt with peer navigation programs and have clinics who make it easy for people to access PrEP. Like in San Francisco, they have a community-based clinic with a nurse-led program, and they have free sexual health services. They're doing pretty good at that first step, but then there's bigger drop-off and retention. And again, some of it is just the nature of our healthcare system where people transfer in and out of care, but we should be able to do better than that, I think. And some of it is the nature of the product. A pill a day or even 211 event-driven PrEP is not for everyone. Continuing on this theme, excuse me, of PrEP in different U.S. cities, shift to New York City, where New York State put a large investment into trying to end the HIV epidemic several years ago. And part of the program that Dimitri Daskalakis, who's now heading the HIV program at the Centers for Disease Control, part of his approach in New York City was to develop status-neutral HIV services. And here you can see a little more detailed cascade, but you can see where the drop-offs are. Again, a little steeper drop-off between PrEP navigation to accepting it to all the way to getting to PrEP linkages and receiving PrEP. But that's a pretty steep drop-off in a city that had dedicated resources to do this. So again, it's just showing us that we need to better understand the reasons for those drop-off. I'll now shift to a tale of Seattle, where I am based, and we were proud to be one of the first cities to achieve 95-95-95, and part of that is by trying to be innovative and responsive to the barriers and treatment cascades, and simultaneously trying to up the targets of PrEP coverage. And so it started out as 30% target of high-risk MSM and now close to hitting the target of 50%. And the way they did this is through state-level PrEP support, and I think Washington State was one of the first states to have a PrEP DAP program, and that really helped a lot because it covers not only PrEP, but it also covers STI services, which end up being not a trivial component of the cost of PrEP delivery. There's a very strong commitment from the county health department, which also has strong linkages to the University of Washington. The STD clinic is one of the biggest providers with about 700 PrEP clients, and also through a community clinic that offers telehealth for PrEP, and then a pharmacy-based PrEP program. And that pharmacy-based program was first reported at CROI in 2017, and it was a one-step it's become a tele-PrEP program. At the time when they reported it at CROI about 4 years ago, they actually would come into the pharmacy, but they didn't actually have to see a physician. The physician was kind of behind the scenes reviewing the lab data, and they've adapted and innovated on that initial model, and it is a highly popular place and a highly popular way for people to receive PrEP without having to incur the costs and inconvenience of doctor's visits. And let's come to Georgia and Atlanta, where Melanie is based. And I want to thank Dr. Erin Siegler for providing some of these data. They have created a program. If you're not aware of it, I just want to highlight the AIDS View program, which really provides useful data at a national, state, county, and even city basis, where you can really drill down on where is PrEP use the highest, and that's in the upper left-hand panel here, where it's showing that really the darkest color is in central Atlanta, but then on the below in orange and red, there it's showing you the map of Atlanta, where actually the need for PrEP based on HIV prevalence in those areas is actually central and south Atlanta. So translating that to a PrEP delivery or uptake to need ratio, there's kind of somewhat of a mismatch, and they need to and are trying to address the need for more PrEP programs and providers in South Atlanta to meet the needs of people living in that area. But they are doing that, and I think the last panel on the lower right shows the increasing trends in PrEP uptake in 2018, 2019, where they're seeing that in Fulton, DeKalb, and Gwinnett counties. I think, again, borrowing from Aaron Siegler and Patrick Sullivan's work, they've done an elegant mapping of PrEP access and some of the policies that underlie some of these gaps nationally. And they came up with this term PrEP deserts, where there are parts of the country where people have to drive more than 2 hours in red. And you can see this on the left-hand side, where there are big areas, big swaths of the country where people have to drive 2 hours to get PrEP. And it's on the right is it's showing those same geographic pattern for people who are uninsured, men who have sex with men. So we've got challenges on this front if we're going to have an impact in the U.S. And another challenge, and I like to remind people about this article that it was actually an opinion piece in the New York Times in 2017, where someone, if I remember correctly, in the southeast part of the U.S., described his experience in talking to a doctor about PrEP. And he was really uncomfortable talking about his interest in PrEP, and and he describes the provider's response saying, well, you don't need PrEP, you don't engage in reckless sex, and you're not a druggie. And it really bothered him, and it made him much less likely to want to take PrEP. So one of the solutions, so that's one of the challenges. Now, one of the successes is coming from Atlanta, and Aaron Siegler and Patrick Sullivan and others have developed a program called PrEP at Home. And they developed this way before COVID, because you can see the publication date here is 2018. And basically they, in a very kind of proactive way, realized that if you're going to get high levels of PrEP coverage, we have to reduce the burden on participants and on and users and on clinics. So this program allows people who are using PrEP to reduce their clinic visits from 4 times a year to once a year. And they basically send out a kit that includes STI sample collection and even a finger stick to get the HIV test from a dried blood spot, with a prepaid mailer, a brief questionnaire, and the results come back to the clinician, and then they can access PrEP. And what they found in their evaluation of this, and this was the early data, where they had about 55 people who were enrolled in it, that 87% wanted to use this instead of coming in for clinic visits, and 40% thought they would have a higher likelihood of staying on PrEP if they had access to such a program. So we can do so much through mail delivery. We've all benefited from that during COVID, and we should really, I think, be expanding on this approach in the U.S., given our fractured healthcare system. Another success from now moving away from the U.S. was reported last month at CROI, when Jean-Michel Molina reported on the Preventer study, where they basically, after they demonstrated efficacy of event-driven, or some people call on-demand TDF-FTC among men who have sex with men, for a little over 3 years, they basically gave people choice to either go on daily or on demand. They did brief and limited lab monitoring. Most people went on same-day PrEP. And then they evaluated, after this had been in place for about 3 years, the impact on new infections in Paris, and they found a 15% reduction in new HIV diagnoses in that time. And so this is really, I think, be been influential in our thinking about offering choice of daily as well as on demand. And there were other data which I didn't have time to include, but I refer you to CROI, where they showed an impact at a national level in France as well. So good progress in parts of Europe. I also want to highlight another country that is teaching us, yes, we can do this, and that is Thailand. And again, I thank Dr. Nitya Panapak for sharing these data, where they looked at their PrEP Cascade among men who have sex with men, and they also she presented on transgender women. So again, I refer you to her AIDS 2020 talk if you want more detail, where she showed that they actually had high effective use, defined as drug levels indicating and self-reported use indicating at least 4 tabs a week, and or correct use of on-demand PrEP. So they had they were showing better than many programs in terms of the proportion, almost 100% after 3 months of effective use, defined as at least taking 4 pills or more per week, or effectively dosing unprotected sex. Another country, or 2 countries, that have taught us we can do this, and we should be able to do this at scale, because I work a lot in Africa, and I really appreciate how hard this must have been to do this. But in the SEARCH trial, which was initially looking at treatment as prevention, they decided in 2016 to 2017 to take that same platform and layer in PrEP, and offered PrEP in 16 communities in the context of these health fairs shown in the picture on the left on the shores of Lake Victoria, where they tested for HIV, screened for hypertension, diabetes, and did rapid tests for malaria. And they, if you were positive, found to be HIV infected, you would get into their programs for supporting universal ART and patient-centered care. And if you were negative, they would do screening for PrEP. And I'll tell you more about that on the next slide. And what they did is they did a risk assessment. And again, I don't have time to go into a lot of details, but it was based on whether or not they had a number of partners, whether or not someone had a known positive partner, or just perceived themselves to need PrEP without disclosing why. And they had basically, out of the 76,000 people, adults who were screened, they had about 21% were determined to be at elevated risk, and about a third of those initiated PrEP. And they had pretty good, given that this was such a large-scale program and it was early in the days of PrEP implementation in Uganda and Kenya, they had pretty high persistence at 6 months. And what was really exciting, and this was reported this year in PLOS Medicine, is that they had a 74% lower HIV incidence in this context at a population level due to PrEP initiation. They had to deal with a lot of barriers and respond to these in terms of rumors in the community, huge amount of stigma about taking a pill that looks basically identical to treatment, fears of whether they would be stigmatized based on taking PrEP as being seen as promiscuous. Their partners are not always supportive. The pill size, taking a pill daily. A lot of these issues were challenges, but the team was really great about responding to those. And they developed out-of-facility visits and tried to make it easier to use it. And here's a quote that just reminds us that PrEP is new, and women, in this case, this woman said, I would like to use it, but my worry is I don't know anyone who's benefited from PrEP. So it is different than treatment, where you can see people gain weight, have a visible impact on their life. PrEP is much less visible. So lesson 1, and I'll start wrapping up now, is that we need interventions to increase PrEP motivation. And one thing I think many of us have learned is that we have to move away from some of our old public health style messages about fear of acquiring HIV and make this much more gain framing, positive about health promotion and empowerment. And I'll show you some examples of that. We have to grapple with the fact that we're not very good at recognizing risk as providers. We're not good at recognizing it in our patients, and at individuals, there's often a discordance. At an individual level, there's also often a discordance between perceived and actual risk, and we see this a lot in young women in Africa, where their risk is really their partner's risk, or they're not knowing their partner's status. And I think we had to learn this the hard way in parts of Africa, that branding PrEP for high-risk individuals made it harder to get it into the general population, and in populations where people did not view themselves as being at high risk. So one of the things to address that is demand creation. And I think this has been a fun area where we've learned a lot, that we have to engage the populations we're trying to reach in developing captivating, effective messaging, listen to the PrEP users in terms of what PrEP offers them in terms of decreased anxiety, increased confidence and trust in relationships, increased self-efficacy, sexual pleasure and intimacy, and truly empowerment. Chicago led the way with a campaign that engaged a lot of stakeholders to develop more sex-positive messages, where they sort of played off some of our epidemiologic terms like catching something or transmitting something to make it about catching desire, transmitting love, contracting heat, spreading and tingling. So I think it can actually be a fun aspect of PrEP delivery, is to figure out what are the things that will engage people. And I'll just take you through a video that we've developed in
I have big
South
dreams
Africa.
and bigger plans. I'm prepared for life's twists and turns.
I'm in control.
PrEP is a new pill you take every day to stay HIV negative. It's like a pregnancy prevention pill. If you take it every day, you won't fall pregnant. And if you take PrEP every day, you won't catch HIV.
If I've been taking it, I know I'm protected.
I'm looking out for my future. I use it because I want to be in control.
So that was a 90-second video that took us a long time to develop, but it was actually great because we heard back from young women in this Cape Town township about how they wanted PrEP to be reflected and what would motivate them. So there have been a number of examples. The Kenya program was one of the first to really take on PrEP on a large scale in Kenya. And again, just very colorful, simple images that draw you in. Thailand, they tried to develop gain frame demand creation to create awareness and interest among transgender women, and were able to determine through at least one survey that it increased uptake in one of their PrEP programs in Bangkok by over almost 300% in late 2020. So we have to get the message out, but we have to do it in creative ways and engage our community partners in helping us get the message right. A second lesson is we need interventions to increase PrEP access. And this is where we can also build on our learnings from treatment access to make it easy, affordable, available, and acceptable using community-based delivery and key population-based models, pharmacy-based telehealth, and express services. one of the things we developed with bedsider.org to try to help PrEP access in South Africa was a decision support tool that sort of takes people, prospective users coming to primary care clinics through what is PrEP, why take it, how well does it prevent it, but without statistics, just in these buckets of the good stuff, the annoying stuff not to worry about. And we found that this doubled PrEP persistence in young South African women being more informed users. In Thailand, in part due to COVID, they developed more mobile delivery programs for PrEP, as well as STI self-sampling, and found not only was it helpful in responding to keeping PrEP access up during COVID, but also users liked it. It was convenient. And lastly, we need interventions to increase effective use of PrEP. And I think that we need to, as clinicians, for those of us who are clinicians, need to think about PrEP differently than ART. We need to help people evaluate and continue to reevaluate their PrEP needs and how, whether they want to continue it or stop, they may want to restart. We need to be better equipped to counsel them and then make it easy to do the testing for HIV, STIs, use telehealth, pharmacy delivery, and other express services. So overall, our goal is to increase PrEP uptake, effective use, persistence, and impact by making PrEP easier for both providers and users. And Moses Kamya at CROI 2021 did a beautiful job in one of the symposia in describing these different concepts about when to when, where, how, what, who, what about delivery could make it better. So in conclusion, I'll say that we are making progress, but we're still limited due to substantial gaps in PrEP uptake and use. The PrEP cascade will always look different than the HIV care cascade, so we need to change our thinking about cascades when we're thinking about prevention versus treatment, because risks change and people's need for prevention will change. And we need to collect information in a way that helps us respond to the gaps and the drop-offs and motivation, access, effective use, and persistence, and learn from oral PrEP about how to address the motivation, how to do better at game framing, community and client-centered campaigns, how to do a much better job at PrEP access and effective use in terms of making it easier for clients to use PrEP, and to use all these lessons to be better prepared for delivering PrEP choice in the near future as we develop, as we implement new options, including dapivirine ring, CAB-LA, and hopefully in the future, islatravir and lenacapavir. So I'll conclude by just thanking the people who shared slides and have shared their experiences and their successes and challenges, and allowed me to share some of those here. Thank you.
And thank you. What a rich talk. And, you're right. We really were just at the beginning when PrEP was approved, and we have so far to go. But I think you pointed out some very positive aspects that we can learn from and hopefully improve where we are. We have a few questions in the Q&A, and Connie, if you would be willing to go in the Q&A and maybe answer those questions. I think we don't have time to address them live and in person. So if you could do that, that would just be awesome.
Okay.
And thank you very much.
Thank you.